Hello, welcome to another episode of Ask the Doctor with Dr. Jeffrey Sherman. Nice to have you on the show again.
Thank you for having me. Good to be here.
Yes. Today, it is May the 21st, 2020, and the CDC reports 1.5 million confirmed cases of COVID-19 and 93,000 deaths in the United States. That's the, shouldn't use the word progress, but it's the next. That's the date, I guess. That's the date.
That's the data we have.
Where we're at. That's the data. That's where we're at today. And today, we're going to talk specifically about the ICU, what it looks like, and some of the machinery that's in there, and I guess anything else that you would need to know if you or someone you know is going to be in the intensive care unit. And to start off, I guess let's talk about this. How does someone the ICU is separate from the ER, obviously, right?
Yeah. The ICU is its own working ward of the hospital. You need a special entry card key for the doors to open for you and close. It's a limited access type of place.
Yeah, and so I guess probably not any kind of nurse or doctor can get in there, right? Like you have to have a key card.
Trained in ICU critical care as a doctor and ICU critical care as a nurse. Yes.
Okay. And is there an airlock with like this? Because it's intensive care. So do nurses and doctors need to wear like very special gear, I guess?
I mean, during the COVID, yes. But generally before this, not necessarily. I mean, nurses would go in and out with their regular scrubs, or if they were going to do a bedside procedure and whatever, they would gown up for that. But generally, I mean, now they're all wearing all the PPE.
Yeah, now it's unique.
Yeah.
Okay. So I guess how the main difference, I guess, between the ICU ward and a regular ward would be probably the equipment available.
It's two things. One is the equipment. Yes, the need for special equipment to be used on sick patients, trained by nurse and doctors who know how to use those equipment, and just the 1-to-1 or 1-to-2 nurse to patient ratio. On the floor in the general medicine, the nurses handle 5-6 patients. In the ICU, the nurse will be in charge of 1, maybe 2, and that's it. So the nurse's attention is focused on you, most of the time.
And I can see why that becomes a problem when there's too many ICU cases, because that means you need a lot more nurses, probably.
Yeah, well, you got to staff the ICU with whatever is the ICU can handle. So if the ICU has 10 beds, you need the nurses to get ready for all 10 of those beds in any given day, because those things can fill up, fast or not, but you got to be ready in case they do.
Yeah, because I guess like a disaster can happen and then you need 10 people in the ICU immediately.
Yeah, I mean,
it's like that could happen
several ways. One of which is, there's a sick patient in the ER. The ER staff determines this is a very sick patient, needs to go straight from the ER to the ICU. So there you go. Or you have a patient in the general floor who starts to, go south and not do so well.
Yeah, get worse.
And they call, personnel and say, hey, this patient's not doing well. They got to be transferred from the floor to the ICU. So there's that way of getting into the ICU. A couple of different ways, and you get in because you need the higher degree of care, the higher degree of nursing, and so you get to the ICU.
Okay. And let's see. So another thing that's been, I guess, talked about a lot recently are ventilators, because these are devices that basically let you breathe for you. Your lungs, your diaphragm rather, doesn't have to work to keep you oxygenated.
Yes, they breathe for you. What happens is the patient is breathing on their own. Either they are, they're not getting enough oxygen to their body. The lungs cannot do it. The patient cannot do it on their own because the illness is preventing good oxygen exchange at the lung level. And so the
Okay.
tissues are not getting enough oxygen. You start to maybe notice that if a patient is breathing rapidly, because the more breaths, the more times oxygen can come in. And number two, they start to get a little bit of blue around the lips. The tips of their
Oh,
fingers are turning blue. That means there's not enough oxygen to the tissues.
I
Also, you
see.
may have seen those pulse oximeter meters being
The
so they
things
get on
that stick on your finger.
the finger. Yeah,
Yeah. Okay.
talk about that. And that needs to be in the 90s of percent. But in the patients who are not doing well, that goes down into the 80s and even 70s. So you'll see the patient not doing well, and then you transfer to the ICU. The ventilator can reverse all those things.
Okay, that's cool. So what I find interesting about that is how even if inside the lungs, there's not great oxygen exchange, a ventilator can still save that person. Because in my mind, what I thought of a ventilator was like it basically just it stuffs it does the breathing that your
Right.
lungs would be doing. But does it do more than that? Because what it sounds like is that if the oxygen exchange is not great, then normal breathing wouldn't work. And so like the ventilator, I'm curious how that
Right.
works,
So
how that
this is the
helps.
key thing on the ventilator. Um, there's a tube, and the tube delivers the air right
Okay.
to the carina, where the main stem bronchus branches out into two, and then it goes into the lungs. So a more direct delivery of the air, because when you breathe, a lot of the volume gets up here and doesn't get to the gas exchange area. It's up
Ah,
here. It gets down there. So
okay.
the volume of gas of oxygen to the gas exchange area is greater. But more importantly, what the ventilator can do is increase the percent of oxygen. We breathe
Oh,
21%
of course.
oxygen
Yeah.
here in the air. A ventilator can deliver 100% oxygen to the tissues. So the more you stuff oxygen, by definition, the more is going to get through to
Yeah,
the
that's
tissues. So that's the key. You can go to 100, and they usually go in multiples of 10, 100, 90, 80, 70, until you're down to 20. And like, okay, well, why does he need a ventilator? Get him off the ventilator. But my point is, the key of the ventilator is delivering that high percent oxygen
okay.
directly to the tissues to help that gas exchange. And patients, even with the 100%, their lungs are so sick that they don't always, they're not doing great.
Right.
But that's how the ventilator can
Yeah.
really sustain you.
That's a good point. That's something I completely forgot is how you can customize the
Right.
air that is breathed into. And so, yeah, you can stuff it with oxygen so that gas exchange happens much more frequently.
Right.
Uh,
There's a blood test that's a tool to help gauge what kind of oxygen the patient would need,
okay.
and how frequently the ventilator needs to breathe for the patient. There's a blood test called the arterial blood gas, or ABG. They get those
Gotcha.
done on the floor, and they often get them done in the ICU. When we do a blood draw, and we're checking for blood count, and we're checking for blood cultures, and we're checking for sodium and liver tests and kidney tests, we're drawing blood from our vein in our arm, and that's no problem. However, this ABG is an arterial blood gas, which means you got to get the blood from an artery,
Okay.
which tells you different things than getting blood from a vein.
That's
It's
interesting.
that arterial blood gas that the numbers, it gives you the pH of the blood, how much oxygen is in the blood, how much carbon dioxide is in the blood, and with those numbers, you adjust the ventilator to get it within a range that you want.
Yeah. Of course, that's a good point. Veins, of course, they bring deoxygenated blood
Right.
away
Yeah.
to the
So
to the heart.
what's the point? That kind of blood does not help you in the ICU setting.
Yeah.
So what you do is you can get, where's a good artery to get blood from? Your wrist, the radial artery. If you always take your pulse down by the thumb side of your wrist on the underneath on the inner half,
Yeah.
right under here on
Okay.
the pulse here, you feel your pulse kind of at your wrist, other side by the thumb side.
Oh, the thumb side.
Yeah,
Wait.
right over there. You feel
There.
a pulse.
Okay.
What you do is you feel the pulse, and then the needle for the blood gas goes right there, and you got to hit that artery. That's what you're going for. The pulse is
All right.
the artery is pulsating. You want to hit that artery. That's where you'll draw the blood. The arterial blood gas, the artery, you don't have to it'll just, the pressure of the artery, just the blood just goes right into the syringe you're collecting it from, and you got to put extra pressure there because it's a pulsing high pressure system. So like I said, the technique is different and what you're looking for is different. So that's a very good tool to help you adjust your ventilator.
That's right. Now, one thing that I've actually found very interesting as well with the artery measurement is that it also measures pH, which I guess, can you go into detail about that? Because I find that interesting too.
Yeah, your kidneys and your lungs regulate your blood pH. You want your blood pH to be around 7.4.
7.4.
Carbon dioxide
is acidic.
It's acidic, so it lowers the pH. So patients who are not exchanging gas, they're retaining CO2, and their pH is coming down. And how can you fix that? You gotta, breathe more. You gotta exhale more. You gotta
oxygen.
Get CO2. The ventilator can help you do that. So when you're on the floor, you get a blood gas, and you see a pH of like 7.05 or 7.12. It doesn't seem far off from 7.4, but that's not good. You want it right by 7.4. So that means they're holding on to CO2. So you got to put them on a ventilator, have them breathe, have the breathing rate go fast. Put the patient on, sedate the patient, and let the ventilator do the work and blow off the CO2. In a couple hours, get another blood gas and watch the CO2 get right to the pH, get closer and closer to 7.4, and then that's where you want your settings, and you can get the patient better. The lower the pH in the blood, you get lactic acidosis.
Oh, that does not sound good.
Start to fail, liver starts to fail, so you cannot be down in the 7.1s, 6.9 even. That's bad. Those are the really sick ones. So you got to get that CO2 out of the system. That will raise the pH.
Yes, and that kind of segues into another good question from the chat. Actually, was how the ventilator, of course, is put down the person's throat.
Yes.
So, can they communicate? I think are they put under?
Yes. The patient is. Here's what happens: the patient is given, Versed, Demerol, fentanyl, things that will knock the patient out to the point where they're not breathing much on their own either. So you got to put a mask on them and bag them while you're setting up or while you're ready.
You're setting up.
So you got to breathe for the patient. Place the tube in through the vocal cords. You got to pass it through the vocal cords into the lungs, hook it up to the machine, and then the machine does the breathing for the patient. So while they're out, you got to bag the patient, manually breathing for them, then to turn the ventilator on, put them at initial settings, get that blood gas, and adjust the settings after you know what the pH is.
Interesting. So, yeah, that means nurses have to be trained in how to ventilate somebody manually in order to give time for people to prepare the machine.
Right. Now, nurses rarely do the intubation. That's more of an anesthesiologist or the house staff there. Usually the anesthesiologists, who are, of course, excellent at doing intubations, because every time they're doing a surgery and the patient is intubated for that too. So they're good at that sort of thing.
I guess, so that also means if they're put under, and of course they're in the ICU, then that would mean that patient should probably have some kind of family member or friend with them, because in order to make decisions, I suppose. Right.
Now, intubation, correct, for all that. Intubation itself is not a consent. You don't need consent for that.
Okay. Yeah.
What you do need is it's sort of like you need consent to not do it. My point is, sometimes patients are so sick, the family and the patient will say, if I get that sick, don't intubate me, and they sign the DNR, DNI, do not resuscitate, do not intubate order. Otherwise, the intubation is on unless called off. And if the doctor's clinical judgment says you need to be intubated, they're going to go do it. And a family member is right there to say, yeah, let's do it, and let's go, and they'll be the decision maker. If ahead of time the patient says, hey, I'm sick, I don't want to suffer anymore, if I'm going down, put me on comfort measures, and that's documented, then they won't do the intubation. But unless that is written, everybody has that intubation order. Is kind of like it's a go for everybody.
All right. So I guess one thing that would result from the ventilator being in their throat is we have another question here about, is that why so many patients have a raspy voice after being put on the ventilator?
Yeah, exactly. So the tube, even after surgery, even after you have a gallbladder surgery or an appendix, or any kind of surgery that may not take so long, even those patients have a raspy voice because the tube, which is not small, it's like a dime. The circumference of the tube is
Okay.
no smaller than a dime, maybe even a little bit bigger, depending on the size of the patient and the size of the tubes change. But it's a big tube that goes right. The vocal cords are like a V, and the
That's
tube goes
right. Yeah, they're a V shape.
right through the tube, and it'll smush the vocal cords and irritate them.
Whoa.
And it sits
Okay.
there for an hour, 2, 3 hours during those surgeries. And in the case of a sick COVID patient, it could be a couple of weeks. So yeah, your throat's going to be sore, your voice is going to be hoarse, and you're going to clear your throat a bunch before a really kind of, and that's just like I said, for a routine gallbladder surgery. So patients go home after having their gallbladder out. The gallbladder's fine; they feel great. They can't speak. That's the problem.
Right. Right. Um, let's see. There was something
But it
else.
goes right by the vocal cords. That's the mistake early on beginners make. By the time you're an anesthesiologist, certainly not. But you got to hit those vocal cords. If you set the tube to the side of the vocal cords, it goes in to the esophagus,
Esophagus. Right.
and that does you no good. And then
No.
vomit comes up the tube, and you don't want that. So you
And
got to be
that's very life threatening, isn't it?
yeah, it can
Acid coming up.
yeah. Your airway is
Yeah.
not protected there, so you've got to be careful about that.
Yeah. When I learned about that, it was actually kind of shocking because it's like people vomit. People sometimes have acid reflux and they have acid from their stomach coming up into their throat.
Right.
But when I heard how if vomit comes up while they're incubating, or not incubating, put
Intubated.
under,
Yeah.
intubated.
You can't protect your airway. That's why when you do the intubation, when anesthesiologists, and they do it well so they know, but to make sure the tube is in the right place after the intubation is done, you listen to the lungs and you listen for good air sounds. If you don't hear those, the tube may be in the stomach, and that would be wrong. You have to hear and confirm the good air sounds in the lungs. Go from
Oh my God, I clicked the wrong button. But that's okay.
there. Somebody's not too happy about the
No,
show.
they're not. But luckily I can block them, so that's cool. I like this. All right. Let's see. So I learned something today, actually, about there being something bigger, or maybe not bigger, but more severe than the ICU, which is something called an ECMO.
Yes.
I guess, what is that? I don't know.
ECMO stands for extracorporeal membranous oxygenation, ECMO.
Okay.
Extracorporeal membranous oxygenation.
Outside the body.
Outside the body. So your lungs are so bad that even at 100% oxygen is not doing it, or you don't have the ventilator supply a guy needs a ventilator, there's not one available, or whatever. The ECMO machine are lungs outside the body. So you attach catheters to the patient's
Outside the body.
yeah. So so you attach the catheters to the patient's blood, where you're taking blood out of them, and then the blood flows out of the patient from a vein to the ECMO machine. The ECMO machine oxygenates the blood the same way lungs would, with oxygen across membranes in the machine.
Yeah.
And then that newly oxygenated blood then returns back to the patient through the in-way in a different access, and it goes back to the patient's body and circulates oxygenated. It bypasses the patient's lungs in favor of the quote-unquote lungs outside the body doing the oxygenation. That's if the patient's lungs are just so bad, 100% oxygen won't do, and they gotta do ECMO.
Right. Yeah.
Do ECMO for primarily actually are premature babies whose lungs are not developed.
Whoa. Oh.
And they attach the babies to an ECMO machine if they're born at 25, 28 weeks. Their lungs are not completely developed, and obviously the baby's in trouble. They attach the baby to the
Okay.
ECMO machine in the neonatal intensive care unit and help the baby survive that way. And then over the course of several weeks, the baby does well and they get off of it. But there's the baby ECMO, which is really what it's mainly used for, and then the adult ECMO for these shortage of ventilators and just out of the body oxygenation.
Okay. And it reminds me of dialysis, actually. It sounds like basically the same process.
Same idea. In dialysis, you have the catheter or the shunts to remove blood from the patient, run it through the dialysis machine, clean the blood just like a kidney would. The clean blood then goes back into the patient and circulates. This is the same idea. It's out and it's getting oxygenated and it's coming back in.
Wow. Okay. So I don't think ECMO is it's not quite what we dub as life support. It's not like the person's brain dead. It's just that their lungs are dead, which is still very, very bad.
Their lungs are dead and the ventilator is not doing the job or not available. Or
not available.
Not being an ICU physician, I'm sure there are other sort of niche uses for the ECMO machine.
Yeah, probably.
But it's life. It's like their lungs are in trouble, which are important, obviously. But it's there to help prevent other organs from failing. And if you can get an ECMO machine in the face of its indications, you can definitely save the patient.
We have a question in the comments now about, wouldn't the patient need PT after being under for so long? Doesn't COVID cause permanent damage to the lungs? I think it's interesting how you don't hear how people recover.
Yeah, there can be some long-term effects. We're not sure exactly what kind of damage that is. Do they need oxygen? Will they be short of breath more easily?
Right.
Are they more susceptible to have some asthma type symptoms and airway disease and airflow trouble? So we're still learning about some long-term things. My sense is that there may be a little bit of a gas exchange issue long-term, not to the point where the patient needs to walk around with an oxygen tank.
Yeah, that's what I was thinking.
But their stamina may be a little bit different. They can still do their exercise, but they may not be as sustainable as it once was. So there is a little bit of that, but not to the point where they're bedridden or they can't pursue their activities. It looks like patients are, at least the younger ones, are coming almost to capacity back from it. But there are potentially some long-term effects in terms of stamina, getting your wind, losing your breath, things like that.
And I think that's a good time for me to bring up again how if you thinking you're at risk for getting COVID-19, then try not to take any Advil or Aleve. Right. Those drugs can and will make the virus, will give the virus basically a boost. It makes it easier to infect your cells.
It sticks to the receptors better and makes the virus a little bit more pesky. It's pesky enough already. It just makes it stick around even longer.
Yeah, I haven't done the research myself, like the raw data, but I believe that cases where young people are getting very, very severe COVID-19 cases has to do with them taking Advil or Aleve, because that seems like a likely cause in having severe cases.
That ibuprofen is so available.
Yeah, it is. It's widely used.
Realize how much they're taking of it until they look back and go, geez, this bottle's gone already. So it's almost, you're doing it without really even thinking about it.
Yeah. Lucky me, I haven't used it. I mean, I'm young, so like I haven't yet found the need for it, but I probably will someday. I'm thinking that's the case. Just me wait. And I know that for some people, Tylenol, they've said, actually doesn't work for them, which is very unfortunate. Right. And however, I imagine there might be a third product out there, like not Tylenol, not ibuprofen, although I wouldn't know.
Aspirin is helpful.
Aspirin, okay.
Aspirin's a good anti-inflammatory. Aspirin doesn't have the effects of what in terms of against COVID, what ibuprofen does. Aspirin does bother the stomach a little bit, though.
Okay.
Cause some ulcers. But what aspirin does do that can be helpful is it thins the blood a little bit. We
Yes,
talked earlier in one of the shows about possible blood clotting from COVID,
that's
and aspirin,
right.
you know, negate the clotting effects by inhibiting platelet function and keeping your blood a little bit thinner, so blood clots are less likely to form. But like I said, aspirin can bother the stomach, and if it thins the blood, a cut on the skin, or a cut in the mouth, or a cut somewhere, or an ulcer will bleed a lot more than it otherwise
Oh
would. So aspirin is not 100%.
no, it's
Aspirin's got
it's
its
not
downside.
it's not foolproof. It's not.
Thinning the blood is a double-edged sword. It's good and bad.
We have a question here from a viewer about this term, the cytokine storm, that's been thrown about everywhere, about how COVID-19 damages your body.
Yeah.
Yeah, the cytokine storm is, let's see, I don't want to get anything wrong, so I'm going to let you talk about it for a bit.
So the cytokine storm is your immune system. So your immune system tries to fight against the COVID, but there is some patients whose immune system is just too strong. It's just too overactive. And a cytokine is the precursor to an antibody, or a precursor to
Antibody.
protection against infection. And you need the right amount of that to produce the right amount of antibodies to get after the antigen or the foreign body inside. If, though, you have this cytokine storm, your body's producing all these cytokines, these proteins, and they're producing all these other antibodies. Your immune system is so strong, it's not only attacking the virus, it's attacking your own tissues.
That's right.
The amount of immune response is so high, it's going to try to get anything it can get its hands on and get it. And that's what happens in these severely ill patients. Their own immune system is attacking their own lungs, it's attacking their own kidneys, and it's your immune system on top of the virus is attacking your own organs, and it's just making it impossible for it to function.
That's right. Yeah, that's
severe inflammation, and that's those are the sickest patients, and the tricky ones.
We have a really good question here in the chat about what we said about Advil. They said they are they're on diclofenac. I don't recognize it, which is an NSAID. I think that's how it's pronounced.
NSAID, yes.
Okay. Is there a risk to taking those with COVID?
Yeah, the NSAIDs is what Advil, Aleve. Those are the same, all in the same NSAID class.
Okay.
Are in that risky group. So
anything as NSAID.
Yeah, Advil and ibuprofen and Aleve are the most commonly seen, but there's indomethacin, there's Mobic, there's Toradol. They're all good anti-inflammatories if you got a bulging disc, or
right
something going on in your back or your neck, or your knee arthritis is acting up. But it's going to get you a little into trouble in the setting of the COVID. You mentioned Tylenol before. That's not an anti-inflammatory and not an NSAID.
Oh, okay.
So it can work for pain. It just doesn't work for the inflammation. So that's why it doesn't work as well in some patients. But it's not going to, while it may not work as well for the pain you're targeting, it's not going to harm you or make the COVID more likely to get you. So right. It's a little bit of a something anyway.
The person also asked if they happen to if we happen to have a link to some kind of research article that talks about the Advil risk. I personally don't have one written down immediately. I'm just putting that out there just in case you happen to have one, or just
no, I don't. I can look for one up for next time. Cite some research, and now there's no randomized controlled trials going forward. We don't have that. We just have some association data, but I'll look for that.
Okay, association data.
Right, that's a good point. Thank you.
So if we do have mostly association data, then yes, it is technically possible that people who have severe cases are taking Advil, but we do have other data that these types of chemicals do this to the body.
Right, and we talked a little bit about some of that stuff last week. That the vitamin D patients did a little bit better. These Advil patients tend to do a little bit worse. The immune system, vitamin C and the vitamin D and calcium, those are the ones doing better. So those are some, where you look back at the case and say the patients who did better had these levels of these things historically. The patients who did worse had lower levels of those things historically. So until we have data going forward, which can take months, and we don't have that now, we can just kind of go with what the patterns have been, and it's just patterns. It's not proof and cause and effect.
Okay. We have a brief question asking about what happens to people who are allergic to bee stings. Is that also a cytokine storm? Allergic reactions, I suppose.
Those are more histamine reactions, which is a little bit different than cytokine. Histamine is the protein released with a local toxin, and it's a histamine, which is anti-allergy. It then displays itself as the allergic reaction, and it can cause swelling in a different way than a cytokine storm does. But it's a similar idea, but a different biochemical reaction and different result. Histamine is more of an itching thing on the skin in the best case scenario. In the worst, it can attack your throat, and it can swell up your epiglottis and cause some airway trouble and breathing trouble. And that's different than a cytokine storm, which is attacking your lungs at the lung level, the kidneys at the kidney level, and so
on. One interesting thing I think about the whole connection between ibuprofen or NSAID drugs and the virus is that, so we know that the virus basically induces cytokine storms in the patient's body, causes their immune systems to overreact and do a bunch of damage that way. And so I wonder if there's a connection because the ibuprofen and NSAID drugs, those drugs seem to target inflammation specifically. Because isn't inflammation like basically the immune system reacting? And so like I'm wondering if that's like why there's a connection there.
It could be the immune system, or it could be just the local tissue. So there's a little bit of difference between inflammation and some inflammation is not necessarily immune modulated, cytokine modulated. So you can kind of connect the dots a little bit, but we need more information. So I don't know about that link between Advil and cytokine storm per se as the cause. It may turn out to be the case down the road. We don't have that information. What we do know is just the Advil can lead to more trouble of the virus planting itself, and then what happens after that in terms of the patient's response to it is up to the patient's body and own cytokine index. Is there a connection between the Advil and the cytokine? That's still going to need some data, some investigation.
So I think maybe we should bring the conversation a little bit back to ICU material, just in case other people joined. And I would like to say, because an ICU is like so kind of serious, if a patient in the ER or in bed is determined to need the ICU, is there anything that a friend or family member can do to help? Like, is there something that they should do, or is it something that should be left to the doctors?
I like, the friend or family member, this primary decision maker has to be identified and available as much as possible, because certain decisions that need some input from this decision maker or durable power of attorney. Usually it's, the wife, the husband, and if it's not that, it's a kid. Sometimes the patients don't have that, and there's a designated person for that. You got to identify that person, have their contact information on the record, and they need to be informed when a consentable procedure needs to be performed, and they have to give the verbal consent. So that person needs to be sort of available all the time, because a lot of the time these procedures happen in the middle of the night, so you got to be ready to go.
Right.
And you can do a telephone consent with the nurses talking to the DPOA on the phone, but they have to be they're at the forefront in the beginning, because the patient, granted, will be able to make their own decisions probably a lot, but if they're on a ventilator, if they're being sedated, for their own protection, or they're just not in a position to make their own decisions, that decision maker has to be at the ready. And if they're there in person, all the better. But ICU have rules. There's only one person allowed to visit. Sometimes they have a bigger group. They want so the patient just has to be identified and available. So in a crunch time when decisions have to be made fast, they can get the consent and proceed before
Okay.
the patient, so they can get it done effectively and in time.
All right. That's good. So the biggest thing that a loved one can do for their significant other, I suppose, is basically just be ready, just be available.
Be ready.
Be ready to be on call, which I think might be a little easy given how you're probably going to have like a bunch of anxiety about your friend in care. So
the nurse is in communication with this person all the time, and then if they need to do an emergency, they need to remove fluid from the lung, they got to call this person and get permission. If they need to do any kind of procedure, a special catheter to check blood pressure in the collarbone vascular system, they got to get consent to do all these sterile procedures. So that person has to be available to agree to that, especially if the patient is on a ventilator and can't answer or sign for their own. They're just not able to.
One thing I realized about the Advil conversation is that, so we've kind of talked about how Advil is not great for your lungs. It makes you more susceptible to the virus and to your infection. However, I think we should also talk about ways to reinforce your lungs against the infection, which we have talked about before on previous shows, about zinc supplements. And one thing that came to my mind about zinc supplements is, could they react with certain medications? Like, because there might be people who are taking some other medications for some condition, and we want to make sure that zinc doesn't react with whatever they're taking.
Right. Well, any medication can interact with any others, and that's can happen at any time. Zinc, in particular, is it's a pretty inert or stable molecule.
Okay.
And it's not, when we talk about interactions, zinc is not a molecule. It's its own little.
No, yeah, it's a metal.
So we talk about molecules interacting with others where there's moving parts. Zinc,
it's its own thing.
It doesn't do that. It's not. You can overdose on iron. You can overdose on calcium. You can overdose on other things, but zinc not so much. And it doesn't really interact. Your system will take in a lot. It'll work, and then you'll just pee out any excess, keeping your blood levels of zinc pretty high. But your body will adjust, and zinc is not one of those things that will affect the liver or the kidneys adversely. It should just be, and it won't interact with any medications you're taking. It'll just be sort of flowing through your body, and it'll be pushed out. You'll use what you got. You'll push out what you don't. And then you'll take another lozenge, and it'll bring up the levels again, and you'll keep the virus from sticking to your lungs. It'll be a good, positive experience.
Yeah, because zinc will, in a sense, lubricate your lungs. They will make it so that the virus cannot quite stick to your receptors as easily. Let's see. So for zinc products, there are some cold suppressing medications like Coldies that actually use zinc as the active ingredient, and those work too, as well as just regular vitamin supplements.
Vitamin supplements, zinc, straight zinc. The Coldies, I think, is the best. You take one of those a day for a while, you're getting just what you need to prevent or to at least minimize any effect of what's going on.
I was worried that it would either react directly with other medications or it would do something similar to how something in grapefruit juice makes it so that your body absorbs more molecules, and that can be dangerous. That's so bizarre.
Yeah, but you have to take a lot of that to make it have that effect.
Okay.
But yeah, I mean, there's some patients who do that, and but a zinc a day, easy to do. I mean, these days it's maybe hard to get your hands on
right. That is a thing.
Products, but if you can do it, and they're ramping up production, you'll be okay.
Okay. I guess one funny thought I had was what would happen if somebody who was taking Advil for some very like dire reason, or any NSAID, what if they were to take zinc alongside the Advil? Like, I think that would help.
Yeah, yeah. The zinc would carry the day. The zinc would be a little bit would be, and that's
Okay.
something you can think about. You can take zinc concurrently. If you're going to take Advil, take some zinc with it.
Okay.
It
That's
doesn't
cool.
completely overcome the Advil, but it helps it. But if you can avoid Advil, that would be the best option.
Right. But like, yeah, like I said earlier, some people just don't react well with
Right, right.
Tylenol.
If you need it, yeah, if you need it, you need it. And I'm not saying if you take Advil, you're going to get COVID. I'm just
No, it's
saying,
not quite that.
yeah, just be aware.
Yes, be aware. And I guess since this is like a COVID-19 conversation, we might as well talk a little bit at the end about, mask usage. You should wear your mask. If there's like people out there who are saying that, oh, you're gonna suppress your immune system because of the mask, that the thing is that they're not considering is that even if that was a factor to consider, the point of the mask is to prevent infection to other people.
Right.
And because regular surgical masks that you see people using aren't actually great at blocking you from getting them, at least when you're in close quarters, because of the size of droplets and all that. But it's great at preventing people from getting it from you.
Right.
And what's important to remember about this virus is that it's asymptomatic sometimes. Sometimes, in fact, a lot of the time, actually, you're going to be able to transmit it without having symptoms. And so you have to be aware of that.
You don't know you're positive.
No, you can never know.
And so you're going out without a mask thinking I'm fine, but you may have it. So you got to wear that mask all the time. And like you said, it prevents everybody else. A little protection against you, but primarily against everybody else.
Right.
And everybody else wearing the mask is protecting you. So
exactly.
If we all do it, we're all getting protected, and that's the best way to stop the spread. The N95s protect the wearer more than the regular other masks.
The bigger ones won't go like a little
N95 all day. You can't breathe well. You just can't do it. So it's not practical to go outside with that. On your jog or whatever. You can't do that. That's for the healthcare personnel. But wearing a mask, even when you're asymptomatic, stops the spread because you still might be positive. You don't think you are, but you don't know because you haven't been tested. So don't risk spreading anything.
Exactly.
And wear a mask.
Let's see. I think one final thing I should mention about remember when you talked about the device that goes on your finger that measures your oxygen level?
Yeah, pulse ox. Yeah.
Pulse ox. Okay. Is it possible for someone to have low oxygen levels and not really know? Like they have to have a device? Okay.
Well, you know, like
in other ways.
If it's an acute illness, you'll probably know.
Yeah, yeah. There's going to be other symptoms, of course.
Breathing fine, and then all of a sudden your shortness of breath and you just can't get it. You don't need the oxygen meter to tell you that you're, below normal. Okay. You got the smokers, the emphysema patients, just who for years have not had great oxygen, and they're feeling okay because that's the way they feel. But you hook them up to the thing and it says 88%. They would know it because they feel the same as they always do, but it's 88% because their lungs are in such bad shape from the baseline.
Right.
You got the
smokers
acute versus the long change. And the acute people would know, hey, if you're used to, breathing fine and then you're struggling, yes. But if you get a smoker who can change from 88 to 82 without even knowing, how will we know? So you'll need the oxygen meter on him to measure it out.
Yeah, okay. I would imagine also smokers have lower oxygen levels as well.
Yeah.
Yeah, okay.
Yeah, at baseline, they're 90, 91. That's not great.
That's quite a lot lower.
Yeah.
That's significantly lower.
Yeah, but their lungs or their system is used to it. Their heart pumps at half the speed. And then that's why smokers it's a slow, progressive. So if you're smoking, go out there and stop.
Go out there and stop. Yes. All right. I think that'll be the end off place for our show today. Yeah. Okay. I was just making sure. I was just checking something else, making sure that Oh yeah, and the kids at vape. Someone in chat said, yeah, that's basically smoke. I mean, you're inhaling airborne chemicals, so it's
Yeah,
like, and nicotine, which is its own thing.
exactly.
But this is not a conversation about nicotine. We can have that and vaping. That can be another time. Thank you for joining us today. I am about to plug in the email. Here we go. There it is. I'm going to plug in an email so that you can contact Dr. Jeffrey Sherman if you would like to set up an appointment.
Yeah,
Because
email.
your office is starting to open.
Yeah, office will be
part-time.
open June 1st on a kind of a limited basis. We'll do some office visits. We'll still do some telemedicine, and we'll do some procedures here and there. We'll see what the demand is before we kind of get back to our previous schedule of block time of procedures and so on. But right now, we'll just kind of take what we can get and schedule things a la carte and go from there. We have hand sanitizer. We've got air purifiers. We've got PP.
Air purifiers.
Everything ready to go. So things should be good to go.
All right. That's great. And of course, if you have any questions about, remember that other regular medicine does not wait. If you have symptoms for anything, for any other potential conditions, you should contact your physician via something called telemedicine, and just give them a call, because it's very important that we don't let other chronic conditions start to fester in the population because everyone's scared to go to the doctor because of COVID. So it's important that you talk to your doctors remotely.
Yeah. Other medical problems do not sleep either.
Mm-hmm. All right. On that note, see you all next week, 3 p.m. Thursday. Thank you, Sherman, for your time. It's always been a pleasure.
Thank you for having me.
All right. Bye. See you next week.
Yeah.